Can you hear me? Yes. Good afternoon, everyone. How are you? Okay. Can you hear me? Yeah. Can I ask how many people do ECMO regularly? VV ECMO. VV, yeah. How many people don't do it regularly? Okay. And the one in the middle? Do you refer or sometimes? Okay. So this one is they call it a demonstration, but I think is a discussion. So I've got quite a lot of slides there that we go through some aspects of weaning from ECMO. But I would really love if we could work together and basically understand a little bit about what you normally do and see whether we can come up with a monitoring sequence that might be helpful to understand patients more likely to succeed in weaning from ECMO and how do we go through the process. So I think the way I see weaning from ECMO is when you look at three components. You look at ECMO gas exchange, which is obviously important, then the native lung gas exchange, and then what the patient can do in terms of effort. But the key thing is just doing it over time, because one of the effects of weaning from ECMO is that you've got a period where the patient does very little, especially low tidal volume, nothing happens, and then something happens very quickly. So I'm just going to say, this is the thing, my experience is this, that normally patients go on ECMO for an oxygenation problem, and then they find it difficult coming off ECMO for a carbon dioxide problem. So if we forget about the initial part, in a way that's quite why it's called extracorporeal oxygenation, and then we think about more the latter part, whether the patient is able to exchange carbon dioxide at a level that is sufficient, so they're not really so much effort. And this is the other thing, that as a consequence, what we need to do is essentially shift all the CO2 production and exchange from the ECMO to the patient. That's the concept of weaning. Do you agree so far with this concept? Okay, this is how we do it. And then this is something to discuss. So we divide, this is a weaning test. So essentially we say, okay, when the patient when the underlying disease has improved, so a chest X-ray, compliance, maybe the patient is breathing spontaneously, patient is hemodynamically stable, we'll do two little tests. One is this oxygen challenge test. Have you come across this? Some people call it silly test, not in terms of SILLY, but CILLY, the person who described it. Essentially, you give 100% oxygen through the ventilator and then measure the PaO2. And the idea is that supposed to measure a certain amount of oxygen transfer to the lung. I don't know what you think about this. It's not very useful to determine weaning. Why is that? Because, as we said before, the majority of the patients don't come off ECMO not because of oxygenation, but because of ability to remove carbon dioxide. So then we want to move a little bit on this side and just measure the CO2 of the native lung through a capnography. Can I ask how many people do that? Do you have a capnography? Okay, yeah. Do you do it routinely? Sometimes. Routinely. Fantastic. And one of the other things, we look at the VCO2 that is removed by the membrane lung and by the native lung, so the total one. Now, can I ask, what kind of ECMO do you normally use? What ECMO machine do you use? Maquet. And how do you measure VCO2 of the membrane lung? Yeah, the membrane. With blood gases. So you take a blood gas where from? While this lady is busy, I'll give you that.
The third section from the circuit.
Mm-hmm.
We take the
you take gas. And you look at what? PCO2 or?
PCO2.
PCO2. So you look at PCO2 difference, which it's quite difficult to obtain the VCO2 from there, but there are some systems now that you can use to measure the VCO2, or you can use CO2 content, or you look at the exhaust of the gas and measure the CO2 from there. We can talk a little bit more in detail about that, but there are at least 2-3 methods that you can use. And what we want to know is that the patient is able to do a certain amount, a certain proportion of the total. So if the patient is very early in the disease and is not able to remove any CO2, it's very hard to wean that patient. Would you agree? Yeah? But occasionally there are some patients where you start with a very sort of, let's say, 40 to 50%, and then you start weaning, and the VCO2 of the native lung starts going up. But we'll talk about that in a second. But we want to have this pre-test criteria. And then we'll do it in 2 steps. And then this is the discussion, because some people don't do that. We didn't used to do it, but now we start doing it because we're doing a study about it. And the first thing we do is we call it deoxygenation test. So basically you reduce the fraction of oxygen through the membrane lung, and from 100% to 60 to 30 to 21. So essentially the patient, we want to know, is the patient able to oxygenate without additional oxygen through the membrane lung? Now, if the answer is no, then that's it. We stop there and go back and try again the following day. But if the patient passes this criteria, and we've got some stopping criteria, usually SpO2, etc., we go into the proper weaning, where now the patient is on 21% oxygen through this sweep gas, and we start reducing the sweep gas flow. And then now, so we need to test whether the patient is able to remove carbon dioxide. And we'll do 5 to 10 minute steps until we reach some stopping criteria. What do you think of this?
But what is the configuration of the ventilator for do that? With oxygen and 100% and...
No, so we keep it on 60% FiO2, the same level of the ventilation. So then...
No, it's only that because you are doing the test, but I don't know what happened with the patient and with the ventilator, you know.
Exactly. So the only thing, this is the idea of some of the stopping criteria, because obviously if the patient starts breathing excessively, the P01 is really high or very low, sort of very negative, or they start working really hard, then the patient is not ready and you go back. So this is the idea of testing it, and we do it in 2 stages for that reason. Now, one of the thoughts is this one, that when you reduce the sweep gas without touching the oxygen, even at 0.5 liters, you are delivering 0.5 liters of 100% oxygen to a blood flow that could be 3 liters. So it's a lot of oxygen that's going through the membrane lung. And often what you see, you don't understand whether the patient is deteriorating or cannot tolerate the oxygenation part or the VCO2 part. Now, if you imagine this, if you reduce the two together and the patient start using a lot of oxygen through increased respiratory effort, then the patient might desaturate because of the excessive work of breathing rather than because they necessarily need oxygen. So we do this test to understand a little bit whether it's completely oxygen dependent or whether it's an effort and CO2 dependent. So this is one of the things that we use during weaning, and obviously you don't need to use them all. But imagine, do you normally wean your patient when they are spontaneously breathing, also on mandatory breathing? So who does it just when they are spontaneously breathing? Okay? And the others assume that you do it even if the patient is breathing in a mandatory way. So if you're doing just on the mandatory way, you would be looking at your left-hand side, but we do it when the patient starts breathing spontaneously. So we look at the right-hand side where you start looking at some of the effort because obviously you have no way to understand from the driving pressure and the respiratory rate alone. So this is your left-hand side, and this is what we do. So spontaneously breathing, we start monitoring some respiratory drive, a little bit of inspiratory effort, esophageal pressure if is available, and otherwise you need to adjust sedation and sweep gas to maintain that level of effort. If the patient is on the safe zone, then we'll go towards the weaning. Otherwise, you need to adjust or the sedation or the sweep gas flow. There is no other way to reduce the respiratory effort. Does that make sense, this one? Yeah? Okay. How do we monitor the contribution of the native lung? How do you do it? So one of the things is just looking at oxygenation, CO2 elimination, but we'll see in a second. Sorry, let me go back. This is a patient. For some reason. It should be a video, but it's not going through. Can you see where the video is working? So this is a patient. She is on ECMO. You can see, millimeter of mercury. This is a 75 millimeter of mercury PO2. Is very low. It's 40 PO2 millimeter of mercury. She's got completely normal pH. What do you think of this pattern of breathing? She's awake ECMO. She's been extubated because she was neurologically completely intact and she wanted the tube out. 25-year-old. What do you think of this breathing? Comfortable? It's terrible. You can see the sternum is going inside. To be able to do that, the pressure that she must be developing is incredible. So clearly she wasn't ready to be extubated, and she had to be sedated and ventilated. But you can see the difference between having completely normal gas exchange and having a respiratory rate or respiratory pattern that is sustainable. So she had the first condition, but she didn't meet the second conditions. And so one of the things that sometimes you can do, you can see this lady had this is an esophageal pressure there, and you can see that she developed respiratory rate of 35, desaturated to 87, and this started getting weaker and stronger and stronger and stronger. And if you see here, this is the esophageal pressure. As the gas flow increased and she had more sedation, that completely normalized. So this will give you an indication that in this particular patient is very clear. You don't need me to say anything because it's very clear. But for other patients, it's much more subtle, and this can help. Other ways of doing it is using the ventilator. You probably know all these things anyway, so shall I skip it? Because do you know how you can measure respiratory drive and effort with a ventilator? Yeah? Shall I skip this one? Okay. So basically this one was another patient. Let me go where you can measure the P01 there. Can make sort of a occlusion pressure there and measure the occlusion, so the most negative part of an end expiratory occlusion. The PEEP there, you make the difference, so 8 minus 4.2, which is 12.2, and then you can multiply by 0.75, and that will give you an idea of the muscular pressure, so almost the esophageal swing without an esophageal pressure. And in this case is less than 13, and this patient was on minimal support and clearly very ready to be weaned from ECMO. I'm going to skip this one because for lack of time. So one of the things that we can do is when we think the patient is ready from a gas exchange perspective, we still don't know whether the ventilation is safe. So one of the options is doing this, is do an end expiratory occlusion or an end inspiratory occlusion and look at the plateau pressure and look at some safety margins. If the patient is safe at this level, then you've got your target achieved, and this is the patient that you can really wean from ECMO and as soon as possible. But if some of these targets are not achieved, you need to think about two things, or three things. One is sedation, the second one is support, and the third one is more ECMO. So these are the issues with, some of the issues with VV ECMO. What else have you found in your clinical practice? What difficulties have you found in the weaning side?
Initially, you can reduce the sweep gas flow quite fast, but the last liter is often the most difficult one.
It is, yeah.
Often for over days, you have to reduce it in 100 milliliter steps.
Yeah, and that's why I think you're right, and that's why we've started doing the 2 steps. Because if you think about that, when you have a patient on half a liter of sweep, how much carbon dioxide is that ECMO removing? Very little. But what it's giving is giving oxygen. Now, if you imagine what does the oxygen do? So you've got half a liter or 1 liter. What FiO2 do you normally use in your ECMO? 100%. 100%. So now you have 1 liter of oxygen at 100% FiO2, oxygenating 3 liters of blood, 3-4 liters of blood. So what is going to happen? Imagine this oxygenated blood. Where is it going to go? It's going to go into the pulmonary arteries. It's going to go everywhere into the lung. And what happens to the mixed venous oxygen is going to be high. So if we have high mixed venous oxygen, what happens to the pulmonary vasculature? Dilates. And if the pulmonary vasculature dilates, then if you remove it very quickly, there is no time for the ventilation perfusion to improve, and therefore your physiological shunt is going to be in excess of what you think should be based on the chest X-ray. So you might have a problem where the patient desaturates before he adapts. So that's why we go very, very slowly to allow that pulmonary artery or ventilation or hypoxic vasoconstriction to go back to normal, because that's the first thing you lose going into ECMO. So does it make sense why that might be useful? And we found that by doing that, you've got less of that problem where a patient is on half a liter for days and days and days. Any questions so far about this? Or any different experience? No? Okay. I want to show you something because if a patient is... I want to show you this one here. This is a little quiz. Okay. So first of all... So if we go back 1 second... I want to show you something that relates to what you were saying in a second. And these are, in a study, the things are most likely to predict poor weaning from ECMO. So obviously low tidal volume, but the most important one is ventilatory ratio, end tidal CO2 to PA CO2 ratio. So everything related to dead space and the ability to remove carbon dioxide. But I want to show you a case, and then we'll see what you think. You need to watch it, and then you'll tell me what you think, and then see who can give me the diagnosis. Okay? So now the question is, can we make this video start? Because otherwise there is no quiz. Oh, not playing. This was my best situation. Not playing. Yeah, I've got a USB-C. You see, okay. So I'll tell you the story, and then... no, just a video. I'll tell you the story. So this is a lady who had influenza pneumonia, 42, 43-year-old. Chest X-ray chest X-ray improving. We do the daily test, fails. Saturation down to 80%, really uncomfortable, etc. Go back. Try the next day. Same thing again. Now she's got tidal volume 600, 700 milliliters. She's got completely normal chest X-ray, and still she can't come off ECMO. Let me see whether I can... It should say weaning from ECMO.
Weaning from ECMO. In which file folder?
Okay, 1 second. Sorry, apologies about this. So if you... in the Brussels, and then weaning from ECMO down. Yeah, yeah. And then the video. We're getting there. That one, yeah. Okay, so... No, if you... We'll see whether we can make it play. Otherwise, I'll describe it to you. Okay, in the meantime, I'll describe, and then we'll get there. So I'll tell you what's happening. So patient is on 3 liters, blood flow, half a liter of sweep, 1 liter of sweep, 98% of oxygen, then sweep from 1 liter, half a liter, 0, saturation down to 81%. Okay? Then we decrease the blood flow from 3 liters, 2 liters, 1 liter, half a liter, saturation 81, 82, 85, 90, 92, 95. What do you think is happening? So low blood flow, so 3 liters of blood flow, gas flow of about 1 liter, decrease the gas flow to 0, patient rapidly deteriorate to 81%. Go. You had some, I saw some sign. Huh? Cannula placement is great.
Was it a
Best
case,
cannula place you can ever find.
Was it a case of recirculation in the system?
No, there is no oxygen, so there is no recirculation. Any other thought? Oh, go back, please. Okay, let's start. Okay, 85%. She's on 4.7 liters. Now we're going to go down on the blood flow. This is the nurse was looking at me and was almost about to kill me. As low as half a liter, maybe 0.3. Do you remember what it was? The SATs was 85 and 86, 87, 88, etc., etc. So if you leave it long enough, it'll go up to 98%. So what's going on? Cardiac output, we don't know, but it's normal. But there is no oxygen, so the cardiac output doesn't really affect. So now she's on half a liter of blood flow, and she's getting better. Fantastic, yeah. So let's say intracardiac shunt. So this lady, and if you can go to the next one, please. This lady had a patent foramen ovale. So basically what was happening was had completely normal lungs, but the flow of blood, which was deoxygenated, went straight through the PFO and at 4 liters. And so even the lungs were perfect, the blood could not be oxygenated. And so she was desaturating. When you reduce the blood flow, then there is less blood going across the PFO and the saturation improves. Now, we've done a study like that, and about 19% of the patient have some form of PFO, and especially, you said something about the cannula, fem. And sometimes it's very little, but sometimes there's a lot of, we call it PFO physiology. Why physiology? Because once you decannulate them, you do a bubble test and it's negative. It's just because of the flow. So just be aware that if you find that you're stuck a half a liter and the patient is right down and the chest X-ray is normal, think an accelerated weaning. So go down on the blood flow quite a lot and then see whether this will fit with a PFO physiology, so an intracardiac shunt, or whether the patient is not ready. So it's not recirculation, because the cannula are blue and blue, dark and dark. It's not cannula position, because she was doing very well, but it's just sometimes could be the jet into the PFO, and it does not mean that the patient, once decannulated, will have a PFO. It's just during high flow. So, yeah, so this is just a very quick run through, essentially looking at the triad of native lung gas exchange, oxygenated gas exchange and effort, monitoring the effort, monitoring the gas exchange, and some of the cases where everything looks great, but the patient doesn't look so great. I think that's it for the time being. Is there any question, anything that you wanted to ask? Go for it.
Would you recommend to wean first the ECMO and then the mechanical ventilation if we are looking for the muscular effort, and it would be easier to measure them with the patient under mechanical ventilation?
Yes, I mean, it's a really good question. So there are very different ways. So if you want to get the patient off ECMO as soon as possible, obviously it's good not to let them breathe. But what we found is that when then the patient start breathing by themselves, some patients then deteriorate. And I don't know how many people find that when you do it from mandatory ventilation, when then you move them into pressure support, how many patients deteriorate. I'm not really sure. But we find that it's much shorter if you let them breathe and adapt on ECMO and then wean them from spontaneous breathing. But there are loads of different techniques, so I can only share what we do, but it might be that what you do is best. Yeah?
I know you got a lot of experience, but what about APRV mode during mechanical ventilation in ECMO patients? Just getting the open lung strategy.
Yeah, thank you. So we do use airway pressure release ventilation in these patients, and some, particularly the ones where we can see more potential for lung recruitment on CT scan. So then we put them on APRV, and then it becomes very easy because you can just reduce the sedation, and patient will breathe on top of the APRV. So that will be absolutely fine. Yeah, you can do that. So we do a CT scan in every patient as they come in, because 99% of our patients come from other hospitals. So as we come in with the mobile ECMO, we go on the left-hand side, there's a CT scanner, and we'll do a CT scan with some recruitment CT, so 5 and 45, and then if there is no injurious problem and the lung is recruitable, but we'll go into APRV. Yeah. Okay, I'm sure you are thirsty or you need something, but thank you so much, and enjoy the rest of the conference. Bye-bye.